Thank you very much for the invitation to talk today. So just first of all, a few disclosures. The studies I'm going to talk about were funded by charity money from Chest, Heart and Stroke and the British Heart Foundation. But apart from that, the companies had nothing to do with the studies and no involvement in them, apart from for the syncope study, we were given the patches free of charge by either. A few more disclosures. I'm obviously not a geriatrician. I'm not an acute medic, and I'm not even an ambulatory physician. But I do work very closely with our ambulatory physicians to be able to do some of the work that I'm going to tell you about this morning. So I work in emergency medicine. Emergency medicine is very different now to how it was when I first started emergency medicine. Patients used to more commonly present with single conditions, for example asthma, which you were able to identify, treat, and hopefully send home. And now there's an awful lot more multimorbidity, which we as emergency department physicians found very difficult to manage within the 4 hours that we have in the emergency department. And this slide just gives you some of the commonest presentations that we have through our resuscitation room. You can see sort of the top 4 there are probably not unexpected. Heart failure, COPD, chest pain, stroke, and sepsis. And these are things that are very difficult to be able to turn around quickly, and certainly not really that amenable to ambulatory care. But you've all heard in the papers over the last few months about the increasing presentations to the emergency department, and we really do need to be looking at other ways that we can manage patients in order to be able to try and reduce the strain in the emergency department. So I guess just going back to that slide, you can see right down the bottom there, palpitations come in at number 9 of our resus presentations, and that's the first thing I'm going to talk about. So they're common, an awful lot of presentations to the UK every year, and we find the emergency department is very difficult to manage these patients. Most commonly, patients present and their palpitation episode is finished. You do an ECG, it's normal, you just don't know what to do with them. And commonly we send them home, we ask them to go to the GP, to phone an ambulance, to come back again if they get them again, and commonly the same thing happens, they've stopped by the time they get back to us. So I was thinking there must be a better way than this, and there must be some way that we can actually be able to capture their episode while they're having it. There are more traditional methods of investigation out there. We seem to love doing 24-hour tapes for patients who have palpitations which only occur once a month or so, and we're not surprised that the yield is very low. So the question we came up with was, how can we more efficiently diagnose these patients? So we came across this device, the AliveCore device, which some of you may have seen before. And the idea is that it's a one lead ECG, which the patient can just put their 2 fingers on like this. They can either attach it to their phone or to their iPad or other device. And when they're out doing their shopping and they suddenly get an episode of palpitations, they can sit down, they can record their ECG like I'm doing here. It's not bad, 55 beats per minute standing in front of you lot. And they can then either take it to their GP, or they can email a member of their medical team, or something like that, but they've actually captured a rhythm while they're getting the palpitations. And that is the key thing with palpitations, is that we need symptom-rhythm correlation. So I'm going to tell you first a little bit about the IPED study. So we had 10 participating sites across the UK, and it was a multi-centre randomised controlled trial of patients who were 16 or over, who presented to the emergency department, whose underlying diagnosis wasn't obvious when they were with us. So, for example, if they came with palpitations and they had atrial fibrillation, they obviously weren't included because we had the diagnosis. And we randomised them either to standard care or to the device along with standard care, which we gave them in the emergency department, and then we reviewed them in 90 days. It was difficult study. It was an easy study to enrol to, but there was a lot of disappointment associated with it when patients said, yes, we'll go for that, and then obviously we're in the control arm. So as with any studies, it started slowly, and as we had more sites, we got up to reach our target in the time, and as you can see, we only lost a couple of patients to follow up. So there were it was for palpitations and pre-syncope, but the majority of the patients who we included were those with palpitations. You can see it's a real spectrum of ages, right up to the elderly end of the spectrum. And this, we've done a little bit of work beforehand to see whether older patients were happy using this type of technology. And we found that really up to the age of 75, a lot of patients already had smartphones and more commonly like tablets at home, and were actually reasonably comfortable at using the technology. So that wasn't an issue, and as you can see, we had patients up to 79 in the study. So in the two groups, the outcome was that those that had the intervention, 56% of them, we had a diagnosis, so symptom rhythm correlation within 90 days, and those that got the control, only 10% in 90 days had a diagnosis. So we're quite pleased with that. So what kind of rhythms are we picking up here? So again, not surprising to you, but the majority of the rhythms, about 85%, were all non-cardiac arrhythmia. So these were things like sinus tachycardia, ectopics, and about 15% were other things. And the commonest things were SVT, atrial fibrillation, and and a flutter. We weren't expecting to pick up anything more malignant than that. Obviously, these patients present in a different way. They present with syncope. So we're quite confident we wouldn't be sending people away to record ventricular tachycardia. And obviously, that's what we found. And this is very similar to all of the literature out there, that this is the underlying rhythms in patients presenting with palpitations. So we looked at the time to diagnosis, and in the intervention group, around about 10 days, and it was about 6 weeks in the control group. Looking for cardiac arrhythmia itself, so in the intervention group had 11 patients who had an underlying cardiac arrhythmia, and in the control group there was only one, which is randomised, so obviously I think 10 patients out there who we still haven't managed to get a diagnosis on in 3 months who were in the study. Looking for the time to make the cardiac diagnoses, again much shorter as we'd expect from previous data in the intervention group, and we did a cost-effective analysis as well, looking at presentations to GPs, emergency departments, time in hospital, other devices, and monitoring that was used during that time, and we showed that it was cost-effective. Patients were quite happy using it. All of the scales that we looked at showed that patients found it easy to use and were quite confident using it. So thinking about how we're going to take this forward, we looked a bit more at the data to see when it was these patients actually recorded a rhythm. So did we need to follow them up at 3 months, or could we follow them up a bit earlier? And this really, if you're going to introduce this into an ambulatory care setting, it's important, because if you're going to send off a device for 3 months, you're going to need an awful lot of devices as you start accumulating patients coming back to the clinic. So we found that 93% of patients recorded a rhythm during the first 4 weeks. So we decided, when we then started to implement this, that we would bring patients back at 4 weeks. And if they didn't have a diagnosis at that point, we'd send them back out with a device for another 2 months. And if they didn't record a recording after that, then we discharged them. Case studies are always really powerful, and I went to meet this lady who was part of the study, who lived in Edinburgh and who had come to us twice with an episode where she had palpitations with pre-syncope in a coffee shop, and it got to the point where she wouldn't even go out to walk her dog because she was so worried that this was happening when she was on her own. So she was enrolled in the study. We picked up an episode of AV node ventral tachycardia, and she underwent ablation, and we went back to visit her, and her life pretty much had been changed. She was out and about, back out, visiting friends and things like that, so that was a real win. The service we then set up is the smartphone palpitation service, which is now part of our ambulatory care service. So in the emergency department, if the clinicians and in our acute medical unit, if somebody sees a patient who I described earlier, we initially we bring them back to the clinic the next day. They get fitted with the device, then they go away. They come back in 4 weeks' time, and we see how they're getting on with it. Increasingly now, the ambulatory care team are coming down to the emergency department or to AMU to actually fit the device in the department, and the ambulatory care team in Edinburgh have been absolutely amazing to roll this out. And the reason we can't do it in the emergency departments is that it does require 3 or 4 people who know how to do it. You can't expect, and in a medical unit or on a ward, to have where you have many as 100 staff in the ward to be able to train up to do this. So the ambulatory setting is an ideal place to do it. That protocol, if you're interested, is on our Emerge website under the iPad study. So just got this data yesterday. This is so we've had the clinic in place for 6 months now, and this is our first 3 months of data. So we've had 68 patients referred to it in 3 months. We've lost 4 to follow up, and 50 have been followed up for the total period of time. And out of that, so far, we've picked up 4 cardiac arrhythmias with atrial fibrillation, atrial flutter. We've actually picked up a lot more than that, but certainly in the first 3 months. So that's 4 out of about 50, so about 10%. That's probably the amount that we'd probably expect. But we've also made diagnoses in 33 of them who all had a symptom correlation with a rhythm that wasn't concerning, and they were discharged from follow-up then. And these patients are either, when they're seen in the clinic with a diagnostic rhythm, they're either sent back to the GP or occasionally they might be sent to our electrophysiologist for an appointment. So I'm now going to move on to talk about syncope. Again, this is a very common thing we see in the emergency department, and we struggle with it a lot because as emergency physicians, we're always worried about ruling out things that we're worrying about. So is it serious? If it's not serious, even if we don't know what it is, we might be happy to send someone home. But with syncope, emergency physicians always seem to overestimate the risk of it being a cardiac cause. So we admit about 50% of patients. A lot of these patients come in for 24 hours, they sit on the ward. We have hardly any monitors in monitored beds in Edinburgh, so they don't get monitored overnight, and very little is done until they get discharged home. So it's difficult. We don't really have a solution to how to better manage these patients and how to be able to reduce admissions, although I think we probably could send a lot more of these patients home if we had good follow-up afterwards. So how can we reduce admissions and better diagnose cardiac arrhythmia, which for emergency physicians is something that is the main thing we're concerned about. Obviously, in the older patient, you worry about postural hypertension as well, and other lots of multi-morbidity factors that can cause this as well. So we have to think about that as well. But I think predominantly one of the things we need to worry about is this underlying cause, and that's one of the reasons that we do worry about admitting people. So there's a couple of studies looking at whether an observational unit can be of any use. So do we monitoring the patient for 6 hours? And these studies have shown that it might be beneficial. It certainly reduces the length of stay, its cost effectiveness. It's cost effective. We can monitor someone for 6 hours, maybe get an echo if they've got any signs of structural heart disease. But there's not many sites in the UK that do this. Lots of places do have observational units, but not many put syncope patients through them. And also, I don't think we know who to monitor and for how long do we need to monitor them. So this was a question we had a few years ago. And risk scores in syncope, I don't think the ones that we've got at the moment are particularly effective, and none of them been shown to be any better than clinicians making a diagnosis for admission or not. The Canadian syncope risk score I've just put up here. This was derived a couple of years ago, and a subsequent paper has actually looked at whether we can use it better to stratify those patients we need to monitor. Obviously, it's a really common condition, and the reason that we don't monitor very many patients is that the system seems to be, they come through to, if you've got a setup where you have a good syncope clinic, syncope service, people can get monitoring there. If not, they tend to wait till they see a cardiologist before they get monitoring. So it's a real, you need to have had worrying symptoms. There's quite a high threshold to actually get any type of ECG monitoring. If we open that to the front door and we monitor everyone, we're going to pick up a massive amount of asymptomatic rhythm that will really upset our cardiologists and are really not going to be of any benefit. So we really need to focus on who we're going to monitor. And I wonder if this paper is starting to look at that. So using their scoring system, they felt that if you were low risk, you could be discharged after 2 hours just with someone to an ED. These are probably all vagal syncope. If you were medium high risk with 6-hour monitoring, for example, in an observational unit, you could be discharged if there was an opportunity to be able to monitor you in the community. And there's evidence showing that if we do that earlier on rather than months later, that does decrease morbidity and increase patient satisfaction. So how could we do this? So we came across this device, the Zio patch, which some of you may have seen before. And this is a device made by a company called iRhythm. There are other types of devices. There's a Bardi patch, which you can wear for 7 days, and there's a few other devices that start to come into the market. The advantage of them is they're reasonably easy to fit. You just shave the patient's chest area, and it just attaches onto the patient's left side of the chest or in the midline. So we wanted to look at, if we were going to patch people who we didn't have an obvious underlying cause in the ED, were we going to be picking up lots of asymptomatic things, or were we actually going to make any diagnoses that were actually of importance? So we fitted everybody who had an unexplained cause of syncope in the emergency department over a year. We were looking at significant arrhythmia, and we divided it into serious and significant, but we were really looking at our endpoint was a symptomatic significant arrhythmia. So we recruited 86 patients, and as you would expect with syncope compared to palpitations, the age group was obviously higher, so the mean of 63. In 76 of the patches we got back, at this point you actually had to send the patches back to the States to be interpreted. Now they actually go back to the UK and you get a result within 3 or 4 days. So we lost a few somewhere across the Atlantic, but 76 were returned, and 56 of those we made a diagnosis, i.e. that whether it was cardiac arrhythmia or not a cardiac arrhythmia. And I appreciate some of these patients have had lots of other causes for their syncope, but looking at just cardiac arrhythmia, we found symptom correlation in 56 patients. Patients were quite happy wearing it. It's got 14 days, is what the manufacturers say, and the median time was 13.6. And you can see out of those 56, 34 of them had a normal symptom rhythm correlation, so normal sinus rhythm for the 14 days, picked up during the 14 days. We compared that to a cohort of patients we'd admitted with syncope, we'd seen in the ED with syncope over the previous 2 years, and so we picked up in 11% of patients we picked up a serious symptomatic significant arrhythmia, whereas with standard care we were only picking up in 2% of patients at 90 days. Again, we looked at the 14-day period to see whether 14 days is necessary. Can we just patch for 48 or 72-hour Holter or 7-day Bardi patch, for example? And whilst there were more symptomatic rhythms picked up earlier on, the tail does go right out to the 14 days. So probably I think a 14-day patch is probably better than a 7-day patch. Again, patients were reasonably satisfied with it. We had no negative feedback, apart from one lady who kept recording on her ECG lots of button presses over one day, but then didn't really have anything else after that. And it was only after going into this bit more detail we found that she was looking after her 2-year-old son that day, and he quite liked the fact that when you press it the light comes on. So he was doing this about 10 or 12 times during the day, and she didn't realise that was the problem. Again, another success story with this. This patient was in his 40s, had an episode when he came into us with syncope. I think we discharged him home. He came back in 3 or 4 days later with another episode, having never had one before, having sustained fairly severe burns to his front of his chest, having spilled a cup of tea. So we patched him, and he sent the patch back. It was sent off, and he had a 28-second pause, which probably vagal, but obviously pretty vagal, and this caused him to lose consciousness. And again, he got to the point when he really didn't want to go out because it was happening once a week or something. So he actually had a pacemaker put in, and he was so pleased with this that he's now one of our patient advocates and does lots of our PPI work. So where do I think we can go with some of this technology from the syncope point of view? I think some of these ambulatory patches do open up the opportunity to be able to put some of this technology earlier on into the patient's journey in the emergency department and the acute medical units. It doesn't have to necessarily be only prescribed by cardiologists. I think we need to be careful who we patch, and I think there probably does need to be some kind of scoring system for who we patch to make sure we're patching the right patients and we're not picking up lots of unnecessary asymptomatic rhythms. I was amazed with some of the reports of the patches of people who, over 14 days, had thousands of episodes of SVT and AF, but only of such short duration. It was 2 or 3 seconds or so. We had a reasonable number of those. I didn't get to patch myself, but I thought that might be something quite useful to do, but maybe it probably wasn't the best thing to do, because I'm sure if we do that, you just pick up lots of things that are abnormal. So we need to be very focused. I think things like the Canadian syncope score may have some use in the future with being able to decide who we can and can't, and then also, do these things actually make a difference to what physicians do? So if somebody has a safety net of putting a patch on somebody, will they be happy to send someone home from the department? And there's nothing out there to show that admitting people to hospital has any effect on outcome. But it's really just getting our emergency physicians to be comfortable with being able to do that, and be happy with the fact that they're not sending someone home to have their episode of VT as opposed to being in hospital. So just to summarise, presented 2 conditions, palpitations and syncope, where I think there may be some use for some of the novel ambulatory devices and monitoring devices that are out there. And as I said, I'm happy to share the experience of Edinburgh with the palpitation service, and that the thing is available on our website. So thanks very much.